y'all, welcome back to my channel. If you haven't been here before, my name is Julie and I primarily make content surrounding topics such as mental health, makeup, as well as music. Today's video is for my Let's Get Clinical series where I read about various mental health conditions in the DSM-5 to educate you on the symptoms, prevalence, as well as treatment of various mental health conditions. We have been talking about eating disorders for the past few videos, and I'm going to continue with that. Today we are going to be talking about OSFED, which stands for Other Specified Feeding or Eating Disorder. This also is known as EDNOS, or Eating Disorder Not Otherwise Specified. So this is going to be a diagnosis for individuals who may have symptoms of various eating disorders, but they don't officially qualify for a diagnosis. There are presentations of other eating disorders that are specifically listed in this section. Let me read to you about it. This category applies to presentations in which symptoms characteristic of a feeding and eating disorder that cause clinically significant distress or impairment in social, occupational, or other important areas of functioning, but don't meet the full criteria for any of the disorders in this category. This category is used in situations in which a clinician chooses to communicate the specific reason that the presentation does not meet the criteria for any of these specific disorders. They record other specified feeding or eating disorder followed by a specific reason such as bulimia nervosa of low frequency. I quickly want to mention we also have unspecified feeding or eating disorder, and the only difference with that diagnosis is that the clinician chooses it because they don't want to specify the specific aspect that's going on outside of this person has symptoms of an eating disorder and qualifies for this unspecified diagnosis. Moving forward into these presentations within EDNOS, OSFED, whatever you want to call it, we have atypical anorexia nervosa. So this is when all the criterion for anorexia nervosa are met, except that despite significant weight loss, the individual's weight is within or above the normal range. So I actually wasn't aware of this diagnosis until I read it to you just now, because in my anorexia video, I talked about how I don't agree that the diagnosis should just be for individuals who are that underweight and meet specific BMI standards, because we still can have this condition. So I'm curious if this will go away and it will fall into that, or if this is staying the same, because I'm glad it's here and I'm glad it's still validating that you totally can qualify for anorexia nervosa, but in a separate category due to the weight difference. But I don't want this diagnosis that any one of you out there may have to take away that you have a very serious mental health condition that requires treatment. Next, we have bulimia nervosa of low frequency and or limited duration. So all the criteria for bulimia nervosa have been met, except that the binge eating and compensatory behaviors occur on average less than once a week and for less than 3 months. So this is a diagnosis you can still qualify for. Your clinician is noticing there is a problem with your relationship with food, eating, etc., but the persistence of your symptoms does not qualify you for the bulimia nervosa diagnosis. However, it is still delineated here. Next, we have binge eating disorder of low frequency and or limited duration. So all the criteria for binge eating disorder was met, except the binge eating occurs on average less than once a week and for less than 3 months, exactly similar to the bulimia nervosa persistence. Next, we have purging disorder, which entails recurrent purging behavior to influence weight or shape, such as self-induced vomiting, misuse of laxative, diuretics, or other medications in the absence of binge eating. So this individual is dealing with purging behaviors, but they are not also binge eating. So they don't qualify for a bulimia nervosa diagnosis, but it's still acknowledged that there is an eating or feeding disorder going on with this individual. I have previously read to you warning signs of specific eating disorders delineated by NEDA, or the National Eating Disorder Association. The warning signs for these disorders are entirely similar, and almost all of them are there, since within EDNOS there are possible symptoms going on, whether it's bulimia related symptoms, purging, anorexia, etc. So I'll just read off a few so this isn't too long. Dramatic weight loss, dressing in layers to hide weight loss or to stay warm, being preoccupied with weight, food, calories, dieting, making frequent comments about feeling fat or overweight despite losing weight, evidence of binge eating such as food disappearing, skipping meals, developing food rituals, appearing uncomfortable eating around others, socially withdrawing, fear of eating in public or with others, stealing or hoarding food, drinking excessive amounts of water or non-caloric beverages, using a lot of mouthwash, mint, or gum, which is very common for people with purging behaviors, showing unusual swelling of the cheeks or jaw area, having calluses on the back of the hands that can come from purging as well. Teeth could be discolored or stained. They may look bloated from fluid retention, have frequent dieting, and they may also endure extreme mood swings. Physically, they can have weight fluctuations. Their body weight's typically within the normal range for this diagnosis. They may endure stomach cramps or gastrointestinal complaints such as constipation, acid reflux. They may have menstrual irregularities, concentration difficulties, abnormal lab findings such as anemia, low thyroid or hormone levels, low potassium or low blood cell counts, as well as low heart rate. They could endure dizziness, fainting, feeling cold, sleep difficulties, dry skin, dry and brittle nails, and poor wound healing. Unfortunately, in regard to prevalence for this specific condition, there appears to be a lack of research out there. My guess is because there are 4 specific possible mental health conditions within this diagnosis. According to ANAD, nearly half of patients with this mental health condition have a comorbid mood disorder, and 1 in 10 of these patients tend to have a comorbid substance abuse disorder, which typically is alcohol use. Treatment for OSFED or eating disorder not otherwise specified, EDNOS, whatever you want to call it, is going to vary depending on which condition within this you have. Do you have atypical anorexia nervosa, then you're going to need treatments that are specific to that. If you have bulimia, you're going to need treatment specific to that, or a binge eating disorder or purging disorder. However, within all of these disorders, we have either compensatory behaviors or obsessive and intrusive thoughts. As we know, eating disorders commonly border on OCD because there are obsessions and compulsions, although they are specific to eating, exercise, body image, etc. Many well-known treatments for eating disorders and mental health conditions in general include CBT or cognitive behavioral therapy. This includes a cognitive model where clinicians will help you to analyze your thoughts, feelings, and behaviors and how they're all interrelated and how you can challenge some of these unhelpful thoughts to reduce the intensity of your emotions and hopefully make your emotions more neutral over time. And this is theorized to help positively influence any maladaptive coping mechanisms or compensatory behaviors you may have. There are specific types of CBT. There is CBT-E that has to do specifically with treating eating disorders. However, it's been found to have more efficacy for certain eating disorder conditions more so than others. DBT can also be helpful to treat eating disorders as it has 4 important aspects to it, which include mindfulness, interpersonal effectiveness, emotion regulation, as well as distress tolerance. Individuals with any eating disorder are going to have intense emotions and often be in high distress, which in turn leads to these behaviors and intense anxiety, agitation, mood swings, etc. So it's really important that they learn about distress tolerance and how to bring down the intensity of their emotions when they are in distress. Interpersonal effectiveness is great because this can help them to better communicate with loved ones and improve their relationships and perhaps socially withdraw less, because we know withdrawing socially or isolating is not good for any mental health condition, but especially eating disorders, because it leaves us to be on our own and hear all those thoughts and engage in those behaviors without anyone watching over us. It's really important also socially to connect with our friends and be open with them about what we are going through. Individual therapy can be great. Group therapy can be great. Support groups, I'm not going to recommend online if you watched my previous video. If you haven't, I'll link it down below, but it's because people aren't trained in mental health like me. So if you want the support, check out this channel instead. Psychiatric medication can also be helpful in treating eating disorders, but I am not a licensed psychiatrist or have a formal background in psychopharmacology. So I advise that you reach out to your mental health provider if you are interested in trying medication to treat your eating disorder. All right, that's all I have for you today. Thank you so much for watching. Please give this video a like if you enjoyed it. I'd love for you to subscribe to my channel as well. Leave a comment down below letting me know if you're enjoying this series so far and what other mental health conditions you'd like for me to talk about next. My Instagram is Julie_counseling if you'd like to follow me. My Twitter is JulieCounseling with no underscore, and my Facebook page will be linked down below as well. And I'll catch you on the flip side. Bye guys.